This is a short video designed to give you some information and advice around the likely symptoms experienced by patients who have COVID-19 and require palliative care and how to manage them. We will also tell you about further sources of information and support with managing these patients outside of the hospital setting. This video is relevant to anyone working in South Cheshire, Vale Royal, West Cheshire and Eastern Cheshire who is responsible for caring for palliative patients who have or may have COVID-19. This includes staff who care for people in their own home and in care homes.
Information from countries like Italy and from colleagues working in London tell us that when patients die from coronavirus, either on its own or in addition to other diseases, they tend to deteriorate and die very quickly. This may mean there is not time to put up a syringe driver, but unfortunately, it does not mean they will be symptom-free. The guidance you already have around managing symptoms at end of life is completely appropriate for patients who have COVID-19. This includes the network guidance from the Greater Manchester and East Cheshire Clinical Network, North West Coast Clinical Network, the guidance on the back of the blue booklet for those working in Eastern and South Cheshire and Vale Royal, and the care and communication record in West Cheshire. Please do remember every professional in Cheshire is able to access the 24-hour palliative care advice line run by your local hospice, and we will remind you of numbers at the end of this video. Here is a brief summary of some of the more common symptoms these patients may experience.
Shortness of breath and cough. Shortness of breath can be a symptom of COVID-19, and if a patient already has shortness of breath due to an underlying health condition, then COVID-19 may worsen this symptom. There are a number of non-pharmacological measures that may be helpful, including reassurance, positioning of the patient to aid breathing, and if available, oxygen if there is evidence of hypoxia. Please note that a fan is not recommended if there is any possibility that the patient has COVID-19 due to the potential risk of spreading infection. Both simple linctus and codeine linctus may be helpful in the management of cough. Other drugs that can be used include Oromorph, or if the patient cannot manage oral medication, subcutaneous morphine, either PRN in stat doses or over 24 hours via a syringe driver. Midazolam can also be helpful if there is associated anxiety or distress, and again this can be given via PRN stat doses or via a syringe driver. For starting doses of these medications, please refer to your blue booklet or care and communication record. Patients with severe respiratory distress may need higher doses of morphine and or midazolam to manage their symptoms. If you are concerned about using these medicines or concerned about symptom control for patients, please contact your 24-hour palliative care advice line. Agitation. If the patient cannot take oral medication, midazolam in stat doses or via a syringe driver can be helpful. If the patient is still able to take oral medication, then lorazepam 0.5 to 1 milligram orally or sublingually can be helpful. Lorazepam can be used if there is no midazolam available. Remember to think about possible reversible causes of agitation, such as pain, constipation, or urinary retention. Sometimes in delirium it can be helpful to combine levomepromazine or haloperidol with midazolam via a syringe driver.
Respiratory tract secretions. Remember, any medications used to decrease secretions can cause an extremely dry mouth, which can be distressing for some patients. Glycopyrronium 200 micrograms subcutaneously, PRN 3 to 4 hourly, or 600 micrograms over 24 hours in a syringe driver can be used. Nausea and vomiting. If the patient is already on oral antiemetics and these are working well, these should be converted to a syringe driver and given over 24 hours. If starting something new for nausea and vomiting at the end of life, refer to the blue booklet or the care and communication record for recommended first-line antiemetics. Pain. If the patient is already on oral opioids but is now unable to take them, convert these to subcutaneous over 24 hours via a syringe driver using the conversion charts and ratios in the blue book or in the care and communication record. If the patient has not had pain before, start 2.5 to 5 subcutaneous morphine, 1 to 4 hourly PRN or 10 milligrams in a syringe driver over 24 hours and titrate up as needed.
These are some basic guides around initial management of some of the symptoms patients with COVID-19 may suffer from. We know there may be infection control reasons why non-injectable options may be the best option for some patients in certain care settings with COVID-19. We are therefore working on guidance and support for you around these options, and we are continually updating our Cheshire e-page with the latest guidance and advice. Remember that your local palliative care teams and hospices are there to support you, and in Cheshire we have 3 hospice-run 24-hour palliative care advice lines. I will leave you with some more information around where you can get further guidance and support.